thank Dr. Alvaro for a very interesting talk that sort of took me right back through my history of neonatology. So thank you for that as well. So I'm going to try to get this done in the allotted time and really focus in on how we came to our recommendations from the Canadian Pediatric Society. I had the pleasure of writing this statement on guidance for newborns with hypoglycemia and their management with Dr. Seth Marks, who's an endocrinologist here in Winnipeg as well. So I wanted to give a nod to him. So the objectives, we're going to review the history of neonatal hypoglycemia. And while that may seem like a fairly dry topic, I'm going to try to show you that it's actually been quite an interesting history. We'll try to define, which is something that's actually very elusive, which is how does one actually define hypoglycemia? What is the definition? And then more importantly, or not more importantly perhaps, but equally important, what treatment options exist? And then I'm going to share with you what direction the CPS, or the Canadian Pediatric Society, would have you go. So just a little bit of background on hypoglycemia. A decline in serum glucose is normal, and that happens over the first 48 to 72 hours. The fetal glucose, as you probably know, is about 2/3 that of maternal glucose. And when the tap is turned off, so to speak, and the umbilical cord is cut, the newborn must rely on its own endogenous mechanisms in order to maintain normal glycemia. We know that persistent neonatal hypoglycemia does equal pathology. So what we're really looking for when we're looking for, after the first 48 to 72 hours, those conditions which are truly pathologic and are not just part of the normal transition from the womb will manifest. There is a blurry line, though, where it's sometimes difficult to really distinguish what is persistent hypoglycemia related to pathology versus just a slightly prolonged transitional hypoglycemia. The reason we want to identify the kids that are going to develop true persistent neonatal hypoglycemia is because there is evidence to suggest that we can prevent negative effects on development if we can address the hypoglycemia early. Perhaps the best example of that is Beckwith-Wiedemann syndrome, where originally it appeared that these children all had developmental delay, but then one day it was recognized that if you address the hypoglycemia promptly and prevent multiple episodes of severe hypoglycemia, these children need not necessarily have the same risk of developmental delay as those who fail to have their glucose controlled. Coming up with a cutoff is controversial. I could imagine in the question period, I may get numerous questions, why 2.6 or 3.3 or 2.0, 2.2. The history of neonatology is we've been sort of all over the map. But more recently, I think we're starting to see some evidence to back up some of these numbers that we use. And when we're talking about what normal is for hypoglycemia, or what the threshold is for hypoglycemia, one can look at clinical manifestations. When does the baby become jittery versus when do you start to see changes in physiology? When does the cortisol rise? When do their endogenous catecholamines start to surge? When do you get EEG changes, for example? So when we're looking at developmental delay, there's three real questions that come to mind. The first is there a level? So is it, as I said, 2.0, 2.2, 2.6, 3.3, 2.8, 2.6? Where is the right level? Another question that comes up is duration. So I think we would all suspect or agree that if an infant has one episode of hypoglycemia, they're unlikely to have long-term developmental delay. But if it's repeated insults, that may have an impact. Whoops. And then the third point is what disease. So as mentioned, is Beckwith-Wiedemann syndrome, or those who are SGA, or those who have congenital hyperinsulinism. Are these kids in and of themselves abnormal in the womb? Is the development of these children abnormal such that it's a chicken and the egg? Are the kids who are prone to hypoglycemia more likely to have developmental delay because of their underlying disease and the impact on the development in the womb? Or is it the effect of the hypoglycemia itself? So lots of questions. Alan Lucas, who many of you are familiar with, has done a fair bit of work, that's an understatement, in nutrition, but he also did some work back in 1988 looking at a group of preterm infants, as you can see there. And what he found, and this is where I believe the 2.6 threshold comes from in millimoles per liter, what he found was when you looked at risk of developmental delay, and in particular, you're looking using MDIs and PDIs at 18 months of age, what he found was if you had 5 or more days in which you had hypoglycemia as a preterm infant, those infants began to see a statistically significant rise in the risk of developmental delay. And so this was the first inclination that, repeated low insults below 2.6 could be detrimental to the newborn, and therefore the level of 2.6 came about. As with many studies, though, when they followed these kids up later at 8 years, the effect was less so than at 18 months, but nonetheless, there was a difference seen. McKinley looked at a group of babies that were treated with continuous glucose monitors, which is, I think, a very hot topic in neonatology at the moment. In terms of, we talk about non-invasive, using a continuous glucose monitor that only needs to be calibrated a couple times a day. So he looked at kids who were treated with glucose gel in a randomized fashion and used a threshold of 2.6 millimoles or above for 7 days. And importantly, what he found was that there was no increase in the risk of of developmental delay, whether the kids had severe hypoglycemia greater than or equal to 3 days. As you can see, the lines of confidence all crossed 1. And therefore, the conclusion here was really, if you target a glucose of greater than or equal to 2.6 for 7 days, that should not lead to any risk of impairment. And so that, in theory, would give strength to the idea that maybe 2.6 is the threshold. However, when 2 of the trials were put together in the dextrose trials, while it's true that it did not lead to increased developmental delay, one thing that was quite striking is, and this was, I think, underreported, is that when you look at the risk of disability, while it's true that there was no difference between dextrose gels and placebos, nonetheless, there were 38% in the dextrose gel and 34% in the placebo groups that ultimately were diagnosed using sophisticated testing as having some degree of developmental delay. So again, the question then becomes, is it the underlying conditions that predispose to developmental delay? Is it the thresholds? Remember, this was a single point of 2.6 or above that was used for the full 7 days. So is that reasonable? Oh, sorry, my slides are just stuck. There we go. So when we look at what is reasonable or what is defining normal, Dr. Marvin Kornblath from 1965, and I love this slide because, I think 50, 60 years later, we're still discussing the same thing. What he says is, although extensive literature exists, there is still disagreement over which levels of blood sugar are normal in the neonate and which are hypoglycemic or hypoglycemic. So funny, we're still discussing it today in 2020, soon to be 21. And what Dr. Kornblath published was this nice figure in which he looked at term infants. That was 179 term infants and 104 low birth weight preterm infants. And what you can see is that when you look at the first 2 days of life, the blood sugar in the neonates who are preterm was about 2.8, and the blood sugar in the term infants was about 3.3. And what happened was sometime between 48 hours and 72 hours, you can see in both groups there starts to become a rise. The rise in blood sugar is more pronounced, of course, in the term infants. But the idea is something happens around 2 to 3 days where the normal expected sugars in healthy infants start to rise. So this raises a question of why are we using 2.6 throughout the neonatal stay as the lower minimum threshold? Is that the right number? Very recently, this is within the last 4 months, the GLOW study was published, and the GLOW study looked at, it was an observational study looking at glucose profiles in 67 infants in the first 5 days of life. And these kids were not at risk. So these would not be babies with IUGR or SGA or infants of diabetic mothers, normal babies. And what they looked at was, again, using continuous glucose monitoring. And you'll see that there were repeated heel prick plasma glucoses done. In part, they were done because, as I mentioned, with the continuous glucose monitor, you do need to calibrate it at least twice a day. And so what did they find? What they found was remarkably similar to the data from almost 60 years ago. When you look at the first 24 to 48 hours, the 50th percentile is about 3 for the term infant. Dr. Kornblath had found 3.3. At sometime between 48 to 72 hours, the blood glucose starts to rise. So these two papers are actually quite important, because what they reinforce is, they reinforce, at least in my mind, the question of why have we been using 2.6 for many years, or 2.2 throughout the first 5 days, 10 days of life, and considering that normal. It's actually not normal. When you look at the different guidelines from different organizations, and you look at the one from the Pediatric Endocrine Society at the bottom, and I'm highlighting that because we're going to go through what they said back in 2015. Using these definitions of what a normal blood glucose should be, the PES guidelines would find that anywhere from 25, 50, 60% of infants in the first 5 days of life would actually have hypoglycemia as defined by their standards. And so when you look at the PES, this was published in JPEDS back in 2015. Paul Thornton, Charles Stanley, who are two legends of endocrinology whose name may be familiar to you, made these recommendations. And what they did was they really addressed the post 48 to 72 hours of age timeframe and focused on that. And why this was an important paper was because previous literature had really not addressed this time point specifically. And what they looked at was physiologic and neuroendocrine responses as an argument to suggest you should be looking at a change in threshold after 48 to 72 hours. So what they said was, once you start to see changes on EEG, once you start to see catecholamine surges, cortisol responses, growth hormone responses, insulin changes, that is telling you that the body is suggesting that these numbers are no longer adequate. So they recommended before 48 hours, 2.8 or above, or 50 milligrams per deciliter. And they recommended after 48 hours, 3.3 to 3.9. And they also introduced the concept of a scheduled fast, meaning that babies should be treated with a fast for 5 to 6 hours, just in case. What if the family forgets to wake the baby? What if they fall asleep and they don't wake? They don't hear the baby. You need to make sure for home the baby's safe to go. When we're talking about getting a sample, all of us, I suspect all of us, use point of care glucometers in order to get screening done. A couple things to mention with that: whole blood is 10 to 20% lower than plasma. And importantly, when you're looking at point of care testing, what this translates into is plus or minus 0.3 to 0.6, so a 10 to 20% difference between what you are seeing on the glucometer and what you are seeing in a laboratory specimen. Continuous glucose monitoring, I've talked about numerous times already. There is a lag. There's a lag of as much as 20 minutes comparing interstitial glucoses to serum glucose or point of care glucose. And that has there's practicalities also that you need to consider in terms of where you would site these monitors in a preterm infant, although it has been done. And the picture to the right on the bottom is of a preterm infant that was part of a study in which they used these continuous glucose monitors in preterm infants. Excuse me. When we talk about sending a critical sample, this is typically what we're looking at. You'll notice I've said under 2.8 millimoles per liter. The reason for that is, remember, if there's an error by as much as 10 to 20% in the point of care glucose compared to the serum glucose or the lab glucose, as all of you who have sent critical samples before would know, if you send a critical sample and you get an insulin level, let's say of 15 or 20, but the glucose comes back from the lab as 4, the endocrinologist will say they can't interpret it. So if we're going to be poking babies, as you heard, I have an interest in minimizing pokes. Make sure that the blood glucose is low enough that you'll get a lab result, which will allow you to interpret these results, looking at ketones, insulin, growth hormone, cortisol, etc. When we're looking at treatment, this is one way of looking at treatment. We recommend skin-to-skin care, increasing volumes of fluids, as I think you would all know, breastfeeding to address the needs of the baby. If you're going to feed, you can use glucose gel. Glucose gel should be given with a feed. If the baby still has a low glucose, you could try frequent feeding, you could try continuous feeding. Ultimately, you may go to an IV. Once you've used an IV, and this is beyond the scope of this talk, except to say the other special treatments that are available to you at that point would be octreotide, growth hormone, diazoxide, hydrocortisone, glucagon, which many of you will have used. Now, what about glucose gel? So glucose gel, in case you're not using it, is really the same as a D10W bolus of 2 mils per kilo. So if you give D10W 2 mils per kilo, you're giving 200 milligrams per kilogram. Similarly, if you give 0.5 mils of dextrose at 40% concentration, you're giving the same. So that's one way to think of it. It's like an oral bolus. In the sugar baby study, this was the landmark study done by Harris out of New Zealand, which looked at 514 total enrollment and found when they looked at that primary outcome of having a blood glucose that was still under 2.6 after 2 treatments of dextrose gel. It was a double-blind trial, and and the devil's in the details, because when you look at the outcomes in the sugar baby study, some people dismiss it and say, well, there was no difference in NICU admission. But that's not, that is true. The overall rate of admission was no different. But when you think about it, that actually makes sense that there should be no difference between the groups, because the real reason that many of these babies are going to be admitted is not because of hypoglycemia. It's because they're infants of diabetic mothers that won't feed. It's because they're infants of diabetic mothers, or who have TTN or RDS related to surfactant deficiency. But when you look specifically of babies who were admitted with a primary diagnosis of hypoglycemia, just for hypoglycemia, so they didn't have to be admitted for low birth weight, the difference was almost twofold. So it was about twice as likely to be admitted at 25% rate in the placebo gel group versus the dextrose gel group. Also, there was less formula at 2 weeks of age, which was statistically significant. So that's another win. So balancing safety with overtesting. So this is where, as I hinted, you may want to distinguish, and this is what we've done in the CPS statement, distinguish targets for therapeutic thresholds and thresholds for investigation. And again, you need to be able to order a critical sample, which can be interpreted. So in November 2019, Seth Marks and I published with the Canadian Pediatrics Society this statement, which is available at cps.ca. All of our statements are available there. And we targeted infants with hypoglycemia as defined by the following measures. I won't read them all in the interest of time, except to say you can refer to the paper, and they list off all the typical things that we've talked about some of them being SGA or IDM, but some other things that we included were labetalol use and exposure to late preterm antenatal exposure to antenatal steroids. And this is where, we finally, in a CPS document, talked about distinguishing birth to 72 hours and after 72 hours. Now, you might ask why we didn't go with 48 hours, as the Pediatric Endocrine Society suggested. There was a concern that if you change the threshold to the 3.3 after 48 hours, you might start to see infants who really just had transitional hypoglycemia, who if you just gave them a little more time could avoid an NICU admission. So we were trying to avoid over-investigation, but at the same time recognize, I like to use the grandson or the child, your own child, question of, would you be happy taking a baby home at a week of age who had a blood glucose of 2.7 if that was your child? You probably yourself would want it to be a little bit higher for safety. As you'll see, because of the risk of there being a up to 20% difference, we suggested that you investigate with a critical sample when the blood sugar is less than 2.8. Because if you take 20% of 2.7, that's about 5.5, so that brings you up to 3.3. So 72 hours and beyond, we just talked about this, sorry. So what are the so specifically recommendations were in asymptomatic at-risk infants, you should screen them at 2 hours of age, and that's after a feed, and then every 3 to 6 hours in conjunction with breastfeeding. A lot of people ask us how long you need to test these babies for, and what the evidence pointed to was for all babies other than the SGA babies and the PREMs, If you've gone over 12 hours without a low blood sugar, you can stop testing. In the preterm infant and in the SGA infants, there have been infants that become hypoglycemic on day 2. And so therefore the recommendation is to check these babies at least for 24 hours. And that would be every 3 to 6 hours. So if the blood sugars are coming back in the 4 range or the 5 range, you need not check them every 3 hours. Those babies, I would suggest maybe you could check every 6 hours. But after 24 hours, if the blood sugars are all over 2.6, then you could stop checking. Before discharge, we have endorsed the recommendation of the 5 to 6 hour fast. That makes sense to us for the reasons that I mentioned. And certainly babies should have, prior to going home, a blood sugar at least 3.3. One of the things that I'm very pleased with is in Canada, we have not just the CPS recommendations, we also have the ACORN program, which is the acute care of the at-risk newborn, which some of you may have heard of. In the previous version of the CPS statement, there was disagreement between the approach to management of glucose with the ACORN program and the CPS, and we have now unified the two. And so if you look at the ACORN program, you'll see this same figure. So this figure is available online through the cps.ca website. And what I would draw your attention to is the middle. So first of all, on the left, if you're symptomatic, we recommend IV dextrose right away. But for those kids who can feed and have moderate hypoglycemia between 1.8 and 2.5, we've given people the option of either using dextrose gels, which we use here in Manitoba, or if you are on the west coast of Canada where they're very skeptical of the use of dextrose gels, using measured volumes can also work. And so what our algorithm for treatment provides is either an algorithm which will work for infants who are being fed using measured volumes or breastfeeding, and then infants who you choose to use dextrose gels. Anecdotally, we have not published this, but our own experience with dextrose gels has been very successful. We have seen a trend in reduction in admission for hypoglycemia with the use of dextrose gels and keeping mothers and babies together. So it does work. The second part of the flow diagram is shown below, and I would just draw your attention, without going through all of this, I would draw your attention to the footnotes, because in the footnotes, I think there's very useful information for your hospital if you choose to use these recommendations. So the conclusions. I think, or I hope I've at least demonstrated to you that normal preterm and term infants will experience a normal rise in blood glucose around 48 to 72 hours. That is what nature has intended. We need to balance the identification. You need to balance testing, really. You don't want to excessively test infants who have transitional hypoglycemia, which is normal, but you also don't want to miss kids who have persistent hypoglycemia. So there's a balance to be made there. And the CPS has endorsed both a monitored fast and a change to the use of a 3.3 threshold after 72 hours. And so I thank you for your time. I hope that this has not been something that you've seen necessarily before, and that you've learned something today, and we'll open this for questions.
Thank you, Michael.